Suresh Bharat. Welcome, everyone. We would like to first thank MSG, Dr. Mona Agrawal, sir, for giving us the opportunity to partner for this event. With this, I'll hand over session to you, sir.
Oh, thank you so much. Can you see my slide?
Yes, sir.
Yep.
Okay, so good evening to one and all. Today our guest speaker is Dr. Amer Jaidan from US. He'll be lecturing on 2024 updates in MDS. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, managed by Perfect Square. I thank Mr. Ashish, Mr. Sumit and the team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, and of course our guest speaker, Dr. Amer Jaidan, all our discussants who are eminent hematologists, medical oncologists, and you participants for sparing your Saturday evening if you are from India, and morning or afternoon for those who are from the rest of the world. Tomorrow morning at 11:30 a.m. Indian Standard Time, we have Dr. Claire Harrison from London speaking to us on myeloproliferative neoplasms. Our discussants today are a galaxy of hematologists or medical oncologists from India. Their names are put up here alphabetically. I'll just very briefly introduce them to you. We have Dr. Abha Dubey from Ahmedabad, Dr. Aishwarya Raj from Ahmedabad, Dr. Akanksha Garg from Ahmedabad, Dr. Amber Garg from Raipur, Dr. Ankit Jitani from Ahmedabad, Dr. Ankit Rayani from Ahmedabad, Dr. Bharat Parekh from Ahmedabad, Dr. Bhavin Shah from Ahmedabad, Dr. Chirag Shah from Ahmedabad, Dr. Khushbu Jain from Ahmedabad, Dr. Malini Garg from Varanasi, Dr. Nilesh Jain from Raipur, Dr. Nidhi Jain from Ahmedabad, Dr. Nilesh Vasekar from Nashik, Dr. Pritesh Junagade from Nashik, Dr. Priyanka Srivastava from Karamsad, Gujarat, Dr. Rajan Yadav from Ahmedabad, Dr. Ruchi Aujla from Raipur, Dr. Sandeep Shah from Ahmedabad, Dr. Sanket Shah from Ahmedabad, Dr. Saroj Dhankar from Raipur, Dr. Sailesh Lavana from Vadodara, Dr. Shivani Joshi from Nashik, Dr. Siddhesh Kalantri from Nashik, Dr. Sudarshan Pandit from Nashik, Dr. Suman Mittal from Raipur, Dr. Yashwant Kashyap from Raipur. To introduce our guest speaker, and he is well known to all of you, he has done a number of webinars for us and educated us on various aspects of myeloid malignancies. He is Associate Professor of Medicine, Hematology at Yale University. He is also the Medical Director of Hematology, Early Therapeutic Research, the leader of the Myeloid Malignancies DART, and the Director of CME at the Hematology Division of Yale Cancer Center. He obtained his medical degree with honors from University of Jordan, followed by residency in Rochester General Hospital, Rochester. He then completed a Hematology Oncology Fellowship and a Clinical Research Fellowship in MDS at St. Johns Hopkins University, where he also earned a Master of Health Sciences degree in Clinical Investigation. The focus of his clinical and translational research is the development of novel therapies for myeloid malignancies with a special focus on targeted therapies and immunotherapy-based approaches. He has and continues to serve as the principal investigator of many investigator-initiated cooperative group and industry-sponsored clinical trials for myeloid malignancies. He also chairs or serves on the steering committee of several large clinical trials of myeloid malignancies. He has served as the vice chair of the Yale Cancer Center Data and Safety Monitoring Committee and currently serves in the independent data and safety monitoring committees of multiple clinical trials. He is a member of the MyeloMatch Precision Medicine Initiative of the NCI for both MDS and AML. He's very active within the Cancer Therapy Evaluation Program and Early Therapy Clinical Trial Network in working on early phase clinical trials of novel therapies for myeloid malignancies. He has received several prestigious awards, including the Leukemia and Lymphoma Society Scholar in Clinical Research Award, the NCI Cancer Clinical Investigator Team Leadership Award, the Amsdid Evans Foundation MDS Clinical Research Consortium Fellowship Award, the Tito Bastianello Young Investigator Award, and the ASCO Young Investigator Award, and multiple others. He serves on the editorial board and is a reviewer of several important hematology and oncology journals. He is an author of over 260 peer-reviewed publications and book chapters. I invite him to deliver his lecture on 2024 updates in myelodysplastic syndrome. Over to you, sir.
Yeah, thank you so much, Dr. Agarwal, and it's a true pleasure to join you every year, every other year, to talk about MDS updates. I always love the interaction with a very passionate group about oncology in general and hematologic oncology. So let me share my slides here. Okay. So I think you are seeing the presenter mood at this point. So as you know, 2024 year comes at the beginning of the year, always comes after ASH meeting, where I think there were like some important updates that we discussed, but the year 2023 has seen important developments in the field of MDS. So these are my disclosures. So these are the general outlines I'm gonna talk about today. I'm gonna focus on some of the updates in the classification of MDS, the risk stratification and prognostication, and then response assessment. Then they will talk about the current and new investigational approaches in lower risk MDS, and then go to higher risk MDS. So many of you have been aware by now that the MDS classification has been evolving, and in the year 2022, there has been an important update. Historically, the FAB classification, which goes back to the 70s, has been in use for a long time. Until now, actually, you still see it in path reports and in papers, and even in some clinical trials where MDS was classified into refractory anemia with ring sideroblast, refractory anemia with excess blast, or refractory anemia with excess blast in transformation, as well as CMML, which was early on considered part of MDS. However, in the year 2001, when the MDS classification was revised and actually cancer, MDS was recognized as a cancer for the first time, at that year, CMML was taken into a separate group, so no longer under MDS, and was put under MDS MPN overlap. And then the refractory anemia with excess blast was broken into refractory anemia with excess blast 1 and refractory anemia with excess blast 2, which is defined by the number of the blasts, 5 to 9% versus 10 to 19% in the bone marrow. Among other changes. In the year 2008, the fourth revision was actually introduced, and the year 2016, there was a revision of the fourth edition of the WHO classification. In the year 2022, there was an introduction of the fifth edition of the WHO classification, but importantly, at the same time, there was another classification published called the International Consensus Classification. While there are significant overlap when it comes to MDS, there are important differences. And this is important to be aware of because I think an increasing number of papers and trials and could be using one or the other. And sometimes the condition details could be different between the two classifications. However, both the WHO and the ICC are using a genetic-based emphasis more than morphology. And this has been a recurrent theme where getting the genetic structure and the genetic landscape of any particular patient with MDS is becoming more important. So this is a busy slide. I'm going to share these slides with you so that for those of you who are interested, but this kind of discusses in detail the differences between the WHO and the ICC. We published a comprehensive review on this when it pertains to MDS. But the main changes in both systems was the introduction of a TP53 defined MDS in addition to an SF3B1 defined MDS. This is what's called genetically defined MDS. This was added to the already established 5 deletion 5q. So those 3 categories are defined by the presence of genetic or cytogenetic abnormality. And then the morphologically defined entities, which you can see here listed as XS plus 1 and 2. But importantly, XS plus 2 in the WHO is being named MDS AML. So patients who have 10 to 19% plus, now they are being called MDS/AML according to the ICC. And that is important because it's a way in some countries where they cannot access some of the treatment used for AML, such as venetoclax, to use it in high-risk MDS. And this has become, I think, more important in the last couple of years. And then another important change is that there are a large number of AML-defined genetic changes that can define AML, even if the blast count is less than 20%. In the past, it used to be only core binding factor leukemia. Now you can have a very long list of alterations that, if present, they can define AML regardless of the blast count. And lastly, the WHO classification also defined MDS with fibrosis and MDS hypoplastic. Both of those were not formally defined, but they are still not included in the ICC. And CCAS and CHIP, clonal hematopoiesis of indeterminate potential and clonal cytopenia of unknown significance, both of those were formally defined in these classifications. I'm not going to talk much about this today, about the CCAS and CHIP, but happy to take questions during the Q&A. So some of the important updates, I think, in ASH 2023 were related to trying to harmonize the ICC and the WHO, because as you know, having 2 different classification systems can lead to confusion. In the US, for example, we have immediate release of path reports to the patients once they are signed, even before the doctor has the chance to discuss them. And sometimes a report would say that the diagnosis is this by WHO and that by ICC, and that can confuse patients. Clinical trial enrollment can also be confusing based on which definitions are used, and potentially regulatory drug review and drug approval could be affected by having 2 different systems. So there was an increasing interest in trying to harmonize the 2 systems into one system, and significant effort into this was undertaken by the International Consortium for MDS. You can see here the Twitter or the X handle for it, where we try to take an evidence-based approach to developing a unified system. So the ICC is a global think tank of MDS experts. There's a wide representation from all over the world, largely from the US and Europe, but we have representation also from Asia, South Africa, and South America. And I'm not going to go through the details of like the process, which took almost 2 years, but on a high level, what we did is that we collected data from more than 7,000 patients across the ICMDS from Europe and the US. And we collated all the clinical and the molecular data, as you can see here. This is the baseline characteristics. You can see that this is pretty representative of MDS patients in terms of the demographics, in terms of the IPSSR risk grouping, as well as the frequency of the mutations that are commonly seen in MDS. And then we use the hierarchical strategy to define relevant subgroups using advanced statistical methods of inference, as well as actually artificial intelligence. And this is what the final product of this work, again, summarizing 2 years of work in one slide, that focuses on having one way. So there is a significant overlap with the ICC and the WHO, again, having the genetically defined entities, as well as having morphologically defined entities, but this way you are using one language, one way of describing what the patient has without having to go through two different systems. And we are hoping that this will lead to a bigger push toward unifying the approach into one harmonized system. The other important development in the last few years was the introduction of the molecular IPSSM for risk stratification. As you know, risk stratification is very important in MDS because patients with MDS have a very variable prognosis. Some patients live few months to less than a year, and some patients live more than a decade. And we know for a long time that the karyotype, the cytopenias, and blood transfusion dependency, these clinical factors were very important in defining the prognosis. But there was an increased understanding that the molecular genes, molecular mutations are so important. And there has been a lot of efforts to integrate these molecular mutations into clinical practice. Finally, the IPSSM, molecular IPSS, was introduced where 31 genes are being used to help increase the accuracy of the prediction of the IPSSM. And you can see here that there are 17 genetic variables from 16 main effector genes, as well as one variable from 15 residual genes, which are used to add to the calculator that you can see the website for it. And then the patient would be stratified into one of 6 groups, which you can see to the right lower part of the screen, separated in very nicely into 6 survival curves with very different survival. So this has been introduced in the year late 2021, early 2022, and has been increasingly used in practice. And some groups have been validating it. We wanted also to validate it in a large international database where patients were receiving uniform treatment. And this is important because many of those prognostic tools are used in patients who are getting different treatments, which can affect clearly the prognosis of patients. So here we took an approach of taking patients, all of whom were treated with one uniform approach of hypomethylating agents to try to validate the prognostic tool. And we had, I think, important few findings from this data set, which included more than 1,000 patients from multiple sites in the US, and we are expanding it to Europe as well. In this particular analysis, 900 patients were included. And importantly, we found no difference between azacitidine and decitabine. This is something that has been shown in previous analysis, and I think it's important to remind people that it doesn't matter which drug do you use. I think the most important thing is to look at other factors such as TP53 mutations, complex karyotype, etc. And then we also validated the IPSSM. So the IPSSM is prognostic also among patients who are HMA treated. You can see here very nice separation between the different risk groups among patients who receive HMA, again suggesting that the IPSSM is useful in clinical practice. And importantly, and I think this could be important for developing countries, potentially including India, we actually validated the IPSSM even when you have missing molecular data, meaning that you don't have all the genes, you don't have all the 31 genes. And you could still see that there was a very nice correlation between calculating the IPSSM with missing or with available molecular data, suggesting that this score can be used in practice even in locations where you have more limited genetic testing, where you are not testing all the genes that are part of the IPSSM. And this could be related to the fact that the IPSSM use continuous scores rather than categorical variables for the blood counts as in the IPSSR. Now, moving from classification and risk stratification into some of the therapies and the treatment issues. As you know, in higher risk MDS, unfortunately, we have had a desert of approvals. Many drugs have been tried to be added to HMAs, which have been the standard of care since 2006 in the US, or 2004, almost 24 years now, or 20 years now. and still no improvement, no approval of any doublet. You can see here a list of a very increasing list of drugs that have been combined with HMAs and have failed, the latest of which was magrolimab and sabatolimab as well. And I think this is has been frustrating to the field, but there are, I think, several lessons that can be learned from this. One of them is on the response criteria. So the 2004 response criteria have been problematic, I think, in many ways. I'll give you an example here. This is a complex slide showing the phase 1 data from the magrolimab trial. And what I'm showing here is that among patients who had who responded in this trial, 75% response rate, you can see that in the red rectangle. Most of those responses were marrow CRs, and we know that marrow CR actually does not predict for improved survival in patients, especially those not going to transplant. So I think the way the response criteria has been used with marrow CR has been certainly inflating the response rates and probably leading to some drugs moving from phase 1 to phase 3 that were not very likely to succeed. And I think that caused some of the therapeutic failures we see in phase 3 trials. So to try to address this, we have compiled a working group, international working group, to revise the response criteria, building on previous work from the 2006 and the 2018 efforts. And indeed, this has been revised now, and the paper has been published in Blood for those of you who are interested on this consensus proposal for the revision. And the main highlights from these revised criteria was elimination of marrow CR. So if you only have marrow CR, reduction in the blast count to less than 5% without count recovery, this has been eliminated as a response criteria, as well as stable disease. However, we introduced other criteria where you have count recovery, such as CRL, which is recovery of blast less than 5%, but improvement in one of the three lineages, hemoglobin, neutrophil count, or platelets to the threshold used in the CR, one of the three or two of the three, not all three. If all three, then it's CR. We reduce the hemoglobin cutoff of the CR to 10 from 11. And we introduce CRH, complete response with partial count recovery, in which the ANC threshold is 500 and the platelet threshold is 50,000, which has been already used as a response rate in patients with acute leukemia in the elderly. And this is a busy slide. I refer you to the Blood paper, as well as a summary of this effort that we published in the Cancer Journal for the details of the changes. But in addition to creating these new categories, including a category for patients who start with less than 5% blast, what we call CR equivalent, we also introduced a lot of variable or a lot of standardization in terms of when these assessments should be done. 2 weeks around the bone marrow biopsy time. We also discussed the issue of trying to increase the consistency between people when they review the same data set. The issue is different people, when they look at the same results, they can come up with different response criteria. For example, when do you allow previous platelet use? How do you account for the effect of previous blood transfusion or the growth factor use in the neutrophils? So all of these issues were not very standardized, and we introduced a way to standardize them, which is detailed in the paper. So in the validate database, we sought to try to validate this in a much bigger setting. And we use the validate database, again, a large international database of more than 1,000 patients. For this particular analysis, 726 patients were available. And you can see here the reclassification between the IWG 2006 and 2023, where most patients with marrow CR were reclassified into CR BI or CR uni. A small number of those patients were reclassified into no response or into just HI. So I think this is again showing that many of those patients do have some count recovery, but it's clear that the patients, I think, who have some count recovery with the Moro CR, especially not going to transplant, probably those are the ones who do the best. And we showed that the new categories such as CR limited, which includes CR bi and CR uni, have reasonably good survival, similar to what is with CR. And this was also confirmed in multivariate analysis that looked at age, treatment, receiving transplant, karyotype, TB53, and the IPSSM risk group. So I think it's becoming clear that the criteria, the 2023 criteria, offer important advantages, and probably it will become the standard criteria to be used in clinical trials as well as in practice. Now, moving from classification, prognosis, and response assessment to therapies, which might be more pertinent to, I think, many of the audience on this call. So if I showed you this timeline of approval of therapies for AML, it would be a much busier slide because there are many more drugs approved in AML and CLL and multiple myeloma than it is for MDS. Lower bar is for EMA, upper bar is for the FDA, and you can see we had lenalidomide, azacitidine, and decitabine approved between 2004 and 2006, and then no drugs were approved until the year 2020, when luspatercept and oral version of decitabine were approved. So we are going to start talking by lower risk MDS. Lower risk MDS has seen important changes in the year 2023, especially in terms of the use of luspatercept in the frontline setting based on the COMMANDS trial, which I'm going to discuss in a minute. But this is a typical paradigm. There are different versions of this people kind of apply in clinical practice. But the bottom line is that for most patients with anemia, historically, those patients were receiving ESA. If the EPO level is more than 200 to 500, if the patient has deletion 5q, they would get lenalidomide. However, for patients who are not responding to ESA, the next line of treatment was luspatercept. So what happened in the year 2023 is the COMMANDS trial showed that luspatercept was better than ESA, higher rates of transfusion independence, which makes it as a probably standard of care in the frontline setting in patients with newly diagnosed MDS. And we will talk about these results. So what is luspatercept? So luspatercept is, as you can see, is a fusion protein. It's made of two parts, a modified extracellular domain of the activin receptor 2B, as well as a human IgG1 Fc domain. This is a ligand trap. What it does, it removes the transforming growth factor superfamily ligands from the circulation, because this activation of transforming growth factor pathway has been shown to lead to apparent SMAD activation, which suppresses erythropoiesis. So when you remove these ligands with the ligand trap, you restore erythropoiesis and lead to improvement in hemoglobin production and anemia. And this showed nice results in a phase 2 trial called the PACE trial, which led to the Myelodysplastic trial, which looked at patients who have ESA failure after ESA or not candidates for ESA, who had ring sideroblast. This is important because the first trial looked at patients who had ring sideroblast. And you can see the top line results to the left, that the transfusion independence was 38% compared to 13%, which led to the drug approval. And that was the first trial that led to an approval of luspatercept in MDS. But this, as I mentioned, was after ESA failure and in patients who had ring sideroblast. We have published subsequent follow-up from the Myelodysplastic trial showing that the benefit from the drug extends beyond just ESA, beyond just transfusion independence, which is 37%, but there are actually other benefits. For example, there is a significant reduction in red blood cell transfusion burden, an improvement in hematologic in HIE, even in patients who do not achieve transfusion independence. So indeed, the drug, I think just citing 37% transfusion independence does not capture the full benefit of the drug. In ASH 2023, we have presented data from the Middle East trial, the final update on the efficacy front, showing that when you add the different cumulative periods of transfusion independence lasting more than 8 weeks, because sometimes you can be transfusion dependent for, like, let's say 20 weeks, and then you have a GR bleed and you need a transfusion, 1 unit of blood, but then go into another period of transfusion dependence. This was not captured in the original trial in terms of the duration. So the duration was quoted as 37 weeks. But when you add up these different periods of transfusion independence, you can see here on the slide, the median duration transfusion dependence was close to 110 weeks, almost 2 years. So certainly this is more clinically meaningful. And importantly, in the year 2023, the COMMANDS trial was published, was presented and published. So this was a phase 3 trial in which luspatercept, which is given as 1 milligram sub-Q every 3 weeks and with titration up all the way to 1.75, patients were randomized to receive luspatercept versus Ipotin alpha. And this was a newcomer trial. So those are newly diagnosed lower risk MDS patients with less than 5% blast without deletion 5q. They have to have an EPO level of less than 500 to enroll on the trial. And importantly, they needed to be transfusion dependent, meaning they needed to have 2 to 6 units of blood every 8 weeks for a minimum of 8 weeks. And those patients were randomized, as you can see, between luspatercept and EPO, with the primary endpoint being 12-week transfusion independence coupled with a median hemoglobin rise of 1.5 grams per deciliter. And indeed, this trial met its primary endpoint. So this was published in ASCO 2023, where the transfusion independence with luspatercept was 60% compared to 30% with ESA. And this is important because this is the first time ever we have a drug in the frontline setting beating ESAs. And when you look at the different subgroups, regardless of the EPO level, the red blood cell transfusion need, and the SF3B1 mutation, it was in favor of luspatercept. However, in the group without ring sideroblast, as I mentioned, the COMMANDS trial allowed patients both with or without ring sideroblast, as opposed to the COMMANDS trial, as opposed to the Middle East trial. So here you can see that in the last bar to the right, that patients who were without ring sideroblast, the benefit of luspatercept in terms of the rate of transfusion independence was somewhat similar to that of ESA. However, the durability was better with the luspatercept. And what was presented in ASH 2024, 2023, sorry, just few weeks ago, was the full analysis. So the interim analysis, which was published, which was presented in ASCO 2023 and published in Lancet, led to the approval of the drug, which now is available in the frontline setting and is a standard of care for newly diagnosed lower risk MDS patients who are anemic without deletion 5q, who are needing red blood cell transfusions. So the full analysis was published from the entire data set with longer follow-up in ASH 2024. And again, you can see here similar results, not much change really in terms of the primary outcomes. And importantly, new trials have been started. For example, the Element MDS trial, which is a phase 3 registrational trial of luspatercept versus Ipotin alpha in the first line. However, this is in patients who are not red blood cell transfusion dependent. So the COMMANDS was in patients who are needing transfusions. Here, it's in patients who are not needing red blood cell transfusions. And importantly, they are second-in-class agents. So in addition to luspatercept, there are other agents in the transforming growth factor pathway that you can see here. For example, KER050 or Riticept. This is a drug that is also a transforming growth factor pathway ligand trap, but this acts both on the alpha and the beta. And this has been presented in a phase 2 data you can see here, where it leads to transfusion independence both in ring sideroblast positive and negative, and leads to durability of response. However, this is an uncontrolled study, doesn't have a control arm. Hopefully there will be a phase 3 that looks at this drug. because it's important to have other options for patients beyond the one drug, luspatercept. Another important development from the year 2023 was the drug imetelstat. So imetelstat is a first-in-class telomerase inhibitor. This drug is given intravenously every 4 weeks, and it has been shown in phase 2 data to lead to transfusion independence in lower risk MDS. In the IMerge study, 180 patients, this was a very similar design to the Medalist trial I just showed you, but this trial did not enroll regardless of whether you have ring sideroblast or not, and required a higher transfusion burden at baseline. So you had to have more than 4 units of blood every 8 weeks. Patients were randomized also to receive imetelstat versus placebo, with the primary endpoint being the 8-week transfusion dependence. And again, very positive trial. We presented these data in ASCO 2023, and the paper was published in Lancet just a few weeks ago, where the primary endpoint was also met. The transfusion independence was 40% compared to 15%. So almost 40% achieved transfusion independence at 8 weeks. And you can see with longer follow-up, even for 1 year, transfusion independence and 24 weeks is still significantly better than placebo. And this was with a significant hemoglobin rise. The median hemoglobin rise was around 3.6 grams, so significant hemoglobin rise, and it was durable. The median response was around 50 weeks. Of course, it can lead to thrombocytopenia and neutropenia, but generally those can be managed by drug holding, and they were not associated with an increase in the clinically severe adverse events such as neutropenic fever or grade 3 bleeding between the drug and the placebo arm. But the blood counts have to be monitored, growth factors have to be given, prophylactic antibiotics, almost similar to what you do with HMA. And importantly, this drug could have disease modification impact by reducing the variable allele frequency. Here you can see in a subgroup analysis presented in 2023 that patients who had that patients who also were among the higher IPSSM groups. So just as a reminder, the IMerge trial used IPSS for enrollment, so very low and low. And some of those patients we know are upstaged with molecular data into higher risk categories. So when we look at those patients who were IPSSM higher risk, as you can see to the right, they also still achieved more transfusion independence, which again suggests that this drug could be active in more advanced versions of MDS, which I think are going to be very important trials to conduct. Another update from ASH 2023 was for this drug, which many of us had high hopes for. This is roxadustat, which works on the HIF pathway, the hypoxia-inducible factor pathway. And this had also nice data in the phase 2 setting. However, and this drug actually is already approved in China for anemia associated with chronic kidney disease. But once this drug was taken to this phase 3 trial called the Matterhorn trial, it was negative, as you can see here. The transfusion dependence was close to 47%, but 1/3 of the patients who were on placebo achieved transfusion dependence. And there are a lot of methodological issues with the trial. Most importantly is they allowed patients who only received 1 unit of blood in the last 8 weeks to enroll. So I don't think that this study was a well-designed study, and unfortunately, it's a negative study. So now we talked about lower risk MDS. How about higher risk MDS? So you can see here that we generally divide patients with higher risk MDS into those who are transplant eligible and those who are not. And for those who are not transplant eligible, generally the standard treatment has been HMAs, or in younger occasional patients, AML-like induction. We know that without transplant, patients don't do well. This is an analysis we did several years ago to look at patients with high-risk MDS defined by refractory anemia with excess blasts who receive HMAs without going to transplant, and the long-term survival is only 4%. So I think this is important to highlight to patients that without transplant, it's very uncommon to have very long-lasting responses to HMAs. And an important presentation from ASH 2023 looked at the decision point to recommend transplant to patients with MDS based on the IPSSM. As you may recall, IPSS and IPSSR for a long time were the standard risk tools in the clinic, and we generally recommended transplant based on having IPSS of high risk and intermediate 2, and revised IPSS of very high and high, and some patients with intermediate. But in the IPSSM, after it was introduced in the year 2022, there wasn't a lot of details about how you can use that for transplant recommendation. And this was a large cohort, international cohort, more than 7,000 patients. I'm not going to go through the methods because of time, but the bottom line is that based on the modeling and in a training as well as a validation cohort, patients who had very high, or moderate high benefited from an early transplant recommendation policy, meaning that recommending transplant around of the time of the diagnosis is the right thing to do. So I think this is important as we start to use IPSSM in our clinics. Other updates were from ASH 2023, also looked at the oral decitabine. So many of you know that decitabine, as I mentioned in the beginning, is the other approved HMA. I believe it's available also in India, but in the US, we use both azacitidine and decitabine. And an oral version of decitabine called Aztec 727 was actually approved in the US based on the Ascertain study, which you can see here. So this is the randomized phase 3 study in which we were randomized to receive oral decitabine versus IV decitabine, and this study led to pharmacokinetic equivalence, meaning that the pharmacokinetic exposure of oral decitabine and IV decitabine was similar, and the clinical efficacy appeared to be similar. And based on this, the drug was approved in the US. And one of the most important advantages, in my opinion, of this drug is allows continuous administration, because we do have patients who will not be persistent on treatment with HMAs because they just don't want to keep coming to get injections once a week, every month. And we have published a real-life study in ASH 2024 showing that there was higher persistence on oral decitabine than IV and sub-Q HMAs, especially once you go to longer period, more than 6 months. So hopefully this will correlate with better outcomes over time. Other developments in high-risk MDS included venetoclax. As you know, venetoclax is approved for older unfit AML. It's being studied in patients with high-risk MDS. We have previously shown data in refractory relapse MDS where venetoclax is added as an add-on strategy to azacitidine after HMA failure. And we have shown good responses, as well as that looked at transfusion independence, and around 40% of patients achieve transfusion independence. So this is one option for relapse refractory MDS. From ASH 2023, there was an update that looked at the frontline setting where patients received azacitidine with venetoclax, and more than 100 patients have been enrolled on this study so far. However, most of those patients, almost 60%, went to transplant. So I think it's very difficult to interpret this 26-month survival from this study. But certainly the response rate is promising with this combination, and it remains to be seen how Verona study will read out. So Verona is the randomized phase 3 study that is randomizing patients to receive azacitidine with placebo versus azacitidine with venetoclax. A reminder, venetoclax is used for only 14 days in those patients. And this study is fully accrued, and we are expecting results in early 2024. Importantly, ivosidenib, which is an IDH1 inhibitor, has been approved already in AML, in refractory relapse AML with IDH1 mutation. The data in MDS looks similar, and based on a small group of patients who are enrolled in this pivotal phase 1 study, only 18 patients really, but the results were very impressive in terms of the durability of response and high rate of marrow CR after HMA failure, which is a very difficult setting to treat. The FDA approved ivosidenib, However, the problem is that IDH1 mutation in high-risk MDS is very rare. It's probably not more than 1 to 2%. And there is another drug called olutasidenib, which is another IDH1 inhibitor. This one is not approved for high-risk MDS, but it has also good data. So this could be an option after AZA failure if you can access these drugs. But you have to watch for differentiation syndrome, as well as any side effects that can come up with those drugs, such as LFT abnormalities, etc. And then we have the immune checkpoints, which has been a field that has led to important improvement in solid tumors, but not so far in myeloid malignancies. We looked at a number of traditional anti-PD-1, PD-L1. Those data were generally negative, but we looked at the sabatolimab combination, which is sabatolimab with HMA, as you can see here. Sabatolimab is an anti-TIM3 drug that has been, TIM3 is overexpressed on blasts as well as on T cells, and it could work as an immune checkpoint inhibitor, but also it could directly target the leukemia blast cells. And based on the phase 1 study, a randomized phase 2 trial was done called the Stimulus MDS1, which we just published in Lancet Hematology. The trial did not meet the primary endpoint, which was CR plus progression-free survival, but there was an improvement in the duration of CR, as well as a trend for improvement in the progression-free survival. And importantly, from this trial, we have shown very good correlation between the blood and the bone marrow mutations, which is important because probably could mean that you don't have to get bone marrow to do genetic analysis. You could do it just from the blood. And this has been shown by other groups as well. But importantly, we looked at MRD assessment from this trial, and you can see using different MRD levels, the correlation still held up even when you use 1%, 0.5 or 0.2%. And what we observed is that those patients who had MRD negativity, those different thresholds had better PFS and overall survival hazard ratio, even when you would use a Cox model time-dependent adjustment to rule out immortal time bias related to the different times of obtaining the response. And this trial led to a phase 3 trial, which has now fully accrued, called the Stimulus MDS2. More than 500 patients were randomized to receive AZA with sabatolimab versus AZA alone. So this trial has not been resulted yet, but there was a press release that the primary endpoint was not met. We are hoping to see the results of this trial later this year. And of course, the magrolimab trial, many of you know, the anti-CD47, unfortunately was also suspended despite early promising data, as I showed you at the beginning of this presentation. So there are a number of ongoing phase 3 trials. You can see here 6 of them. 4 have already reported negative: sabatolimab, pibonidistat, magrolimab, and APR246. Venetoclax study is fully accrued, but we do not have results yet. And then there is a 6 randomized study of a drug called tamiparotene, which is a RARA agonist. This is in patients with RARA positive high-risk MDS, which is around half of the patients with MDS. This trial is still accruing, and hopefully one of these 2 trials will be positive, because we do need drugs for our patients with high-risk MDS. And I will finish by saying that despite the failures in high-risk MDS, there's a number of other agents that are being tested, as well as in lower-risk MDS, including IRAK inhibitors and other drugs that we don't have the time to discuss today. And I would like to thank all the funding organizations that supported my work. This is my contact information, and happy to take any questions. Thank you.
Well, thank you so much. Wonderful review and update. So much of data from ASH 2023. It was really a lot of addition to the knowledge that we had. So we'll have an interactive session now with our colleagues from India and others. Dr. Rajan Yadav, your question.
Thank you so much for the lucid presentation, sir. My question, I think you've already answered it, but for a better understanding, I'll ask again. In between decitabine and azacitidine, which one would you choose for an elderly patient? considering I'm not going for intensive treatment?
Yeah, that's a good question. I actually evolved on this question. So, I would say around 10 years ago, based on the AZA 001, which is the only randomized study today that showed OS improvement, was only with azacitidine. So this was azacitidine compared to conventional care regimen. Now, the decitabine randomized studies have shown improvement in responses, and there was quality of life improvement and delayed progression to AML, but there was no improvement in OS. And based on this, most people have been using azacitidine as the frontline treatment in MDS. But what happened is that I think there was an increased understanding that the issue was related probably more to the design of the trials. When you look at the decitabine trials, many of those patients were treated on the old regimen, where patients were being given the drug in the hospital every 8 hours, which is not practical. Now, most of the use is outpatient 5 days a week. And then the important differentiator also is in the decitabine trials. If you achieve the response, the trial stopped the drug after 2 months. And we know that patients usually will relapse once you stop HMA treatment. And we have done, and many groups have done multiple different analyses from registry, from real world. In every single one of those, both drugs appear similar. So right now, my advice generally to kind of patients and providers that I don't think there's a difference whether it's azacitidine, decitabine, or if you have even oral decitabine. I think all three of them are very similar. But the bigger thing in my mind is to actually treat patients, because I did not show this data, but even in the US, more than 50% of patients do not get anything. And there are different reasons for this, but I think one of them is that most patients will look at the data and say, I'm not going to come 7 days every month. They are old. They don't have someone to drive them to the clinic. They don't have a place to get transfusions. The doctors are not very convinced with the efficacy of these drugs, and the survival is somewhat limited. So many patients are not being treated. But I'm optimistic now with the new ways of giving it. For example, the oral decitabine, that you can have more persistence, easier way of giving it. So that hopefully will allow more patients to receive the drug, which hopefully will improve their outcomes.
Thank you so much. Thank you so much. Yes, sir.
Thank you, Dr. Rajan. Just carrying on that question, oral decitabine, did you mention that because it can be given for a longer duration very easily, then it is more effective? Does it have more toxicity also? And how long can one go on?
Yeah, so I don't think we know it's more effective. What we show so far is that it's easier to persist on it. Clinically, what I can tell you is that you probably have the same, but I have a number of patients who achieve full response on IV azacitidine or sub-Q azacitidine, and then after some time, they come to you and say, I cannot continue. I just don't have anybody to keep driving me. I'm just tired of coming 7 days every month. So we have patients who are responding who stop, and that has been a problem because we know that once you stop, you lose the response. So oral decitabine, what we know so far is does increase the persistence. We need bigger studies, and actually, the randomized study that looked at the drug actually had this interesting design where you get IV or oral, and then in the second cycle you switch. So if you started with IV, you go to oral, and then starting the third cycle, everybody goes to the oral drug. So it effectively became almost like a single arm study in terms of clinical efficacy, because everybody was on oral drug after 3 cycles, which prevents us from comparing the efficacy. And because the primary endpoint was the pharmacokinetic equivalence after the first 2 cycles. But I do agree that also the toxicity could be important with this drug. With like any HMA, there is important risk of infection, bleeding. So if you are using these drugs, you have to give the patients prophylactic antibiotics. You have to make sure you do frequent blood work, transfuse them. And if they have infections, you have to hospitalize them, etc. So those are, just because it's a pill, doesn't mean it's less toxic. This is very important to remember.
So like we have 10 days schedule also of decitabine injectable, can oral be given for 10 days, or we have no data on that?
I am not aware of data with 10 days of oral, but what I can tell you, even with IV decitabine, I think most of the data does not suggest significant improvement with 10 days of decitabine, even for TB53. I find it more toxic. even if you start with 10 days, I can tell you the vast majority of patients, even in AML, would go to 5 days within a cycle or two. But I'm not convinced personally that there's a difference. I actually never used 10 days of decitabine.
Thank you. Dr. Saroj, your question.
Thank you, sir, for wonderful update on MDS. Sir, my question is, I would like to know your comments on oral azacitidine in MDS. Like we have oral decitabine approved. What's your comments on oral aza in MDS?
Yeah, that's a very good question. So oral is, I didn't talk about it because it's not approved in MDS, as you noted. It's currently approved in the US after intensive chemotherapy for AML in patients who cannot complete curative intent therapy, so maintenance in AML. In MDS, it was tested, you're right. And I'm talking about oral azacitidine, which is CC486. This is a drug that's different from AZA. This is somewhat different than the oral decitabine because pharmacokinetically, it's not the same. So it's a different drug. And that means it has to be tested in every specific setting. So in patients with MDS, there was a trial in lower risk MDS actually, where there was transfusion independence, but unfortunately, it led to higher early death from infectious complications along the lines of what Dr. Agrawal was mentioning, like, those drugs, especially in lower risk MDS patients, where, the neutrophils might be a bit better and you are dropping them high, certainly you can have more problems with these agents. So because of that early mortality, there was no difference in survival, and the drug was not approved for lower risk MDS. They are working now actually in redesigning this approach with this drug and using shorter courses of oral azacitidine. So maybe it's gonna become available at one point in the future. But I actually wanted to add that there's another version of azacitidine that's combined with sidazoridine. So the same idea that I showed you with oral decitabine is called ASTX030 instead of 727. And this one has just finished phase 1 studies. It was just presented in ASH. And there's an effort. So this would be very similar in the pharmacokinetics. And it's the same approach they are going to take. So if that proves to be positive, I think this drug also potentially could have a place in terms of use in the field.
Okay, thank you, sir.
Thank you. Dr. Abha, your question.
Thank you, sir. So my question is, how do you deal with the diagnosis of ICUS, sir? I have this patient, a 30-year-old female, after extensive workup, twice I have reviewed her bone marrow biopsy at 2 places. Also, she's got second opinion from 2 premier institutes. You're not able to find a diagnosis for her anemia, pancytopenia rather, but anemia is the symptom that is troubling her. I actually tried, in spite of a raised EPO level, I actually tried giving darbepoetin in the absence of another diagnosis. I assumed her gene panel is negative. I assume this is MDS. And I have tried so far darbepoetin for her. I've tried danazol with no avail. Her ANA profile only just showed some positive for F-actin, for which I tried a course of Visalon as well. So my point here being, sir, how do you deal with ICUS? Do you monitor them with serial bone marrow biopsies? Because she has symptomatic anemia, but so far I've not been able to find a cause for that, sir. At least not on the biopsy.
Yeah, no, this certainly can be a therapeutic dilemma. So in general, just for a background for the audience, ICUS versus CCUS, right? So the main difference between ICUS, idiopathic cytopenia of unknown significance, is that you have a mutation in one of the myeloid recurrently mutated genes. So that's what makes it CCUS. So we know that CCUS, in many ways, those patients have very high risk of progression to MDS. I actually many times would go to the pathologist, and the main difference between CCUS and lower risk MDS is whether the pathologist can call enough dysplasia on the bone marrow. So when you have clear evidence, let's say you have 2-3 mutations, splicing mutations, etc., I tend to treat them similarly to how I treat patients with lower risk MDS. So like you mentioned, the ESA,
her myeloid gene panel is negative, sir. I don't have anything to stamp it as even CCUS. This is pure ICUS, sir.
No, I know. And this is what I was saying, but with ICUS, I think it's a different story. I would be very hesitant in someone with ICUS to try to think about HMA or transplant, because in my mind, you have to prove that this is a clonal disorder, because, you know,
Right.
there are many things that can give you anemia, and I'm sure you have looked at everything that,
Yeah.
you know, that should be looked at. But, you know, without, in my opinion, without a clonal evidence of disease, I think it's very difficult to call this, you know, MDS, or to treat it with MDS kind of drugs. I think hormonal treatments, like what you mentioned, are fine. But once you start thinking about things
Correct.
that are more like chemotherapy, or I personally would not do that. I would continue to repeat the diagnostic workup as you have been doing, and hopefully something
Yeah.
is going to reveal itself at one point.
All right. Okay. Thank you, sir.
Thank
Sure.
you. Dr. Akanksha.
Yeah, good morning, sir. Thank you for the lucid talk. So my question is regarding the use of luspatercept. I recently have a patient who was initially diagnosed as hypoplastic MDS with a deletion 13q, and he was an elderly gentleman. So I ended up using immunosuppression with cyclosporin and L-Trombopac. The ATG I was not able to administer because of some logistic issues. So I started the patient on luspatercept, and he responded with just a single dose of luspatercept. His hemoglobin improved from 6 gram% to 9 gram%. He was predominantly having transfusion dependence. So as of now, he has received almost 4 doses of luspatercept, and his hemoglobin has gone up to 12 gram%. So, and the last dose that I gave him was in December 23, and after that, his hemoglobin continues to be above 12. So my question is that, I mean, as per the guidelines, we know that luspatercept has to be continued, for these patients to maintain the response. But in such a case where the hemoglobin continues to be above 12, and interestingly, the patient has also had an improvement in his TLC, the neutrophil count, as well as the platelets have gone above 45,000. So I would like to know your opinion, how to continue with the luspatercept, whether to decrease the dose of it and increase the frequency, how to go about it.
Yeah, can I ask, how long did the patient stay in L-Trombopac and cyclosporin before he went to luspatercept?
So he was approximately 2 months of cyclosporin and L-Trombopac, but he was constantly having transfusions almost every 15 days.
Yeah. So this is actually a very interesting kind of case. A few points on this. First, I actually did not realize that luspatercept was available in India, so that's great. Congratulations. I think it's certainly a good drug. In terms of this particular case, I think your approach was certainly very reasonable. Immunosuppressive therapy, I didn't talk much about it because there was no new data from ASH, but certainly can work with some patients. Like you, I hesitate to use ATG in the very old patients because of the, you know, toxicity. So I think L-Trombopac and cyclosporin are certainly reasonable. Now, you know, we know this approach, L-Trombopac and cyclosporin, can take few months to work in some patients, can take, you know, 2-3 months. So I wonder in your case whether there was some delayed impact from these treatments that you are seeing now. The reason why I wonder about this is that generally we don't think of luspatercept as a drug that maintains response once you stop the drug. I mean, the response could stay, I don't know, a few months, but I cannot imagine someone having a lasting response because we don't think of luspatercept as disease modifying. With lenalidomide, on the other hand, lenalidomide in deletion 5q, there's actually data that some patients who stop the drug could stay transfusion dependent for years, almost like what, you know, therapy-free remission, like what you do in CML. This is not the case with luspatercept, at least so as far as we know, and we don't expect it based on the fact that the drug doesn't modify the disease in the way that lenalidomide does. But you are also bringing, I think, another important issue is that with luspatercept, we have seen also improvement in platelets and neutrophils. I didn't discuss this, but around some patients get improvement in other lineages as well, not to the extent that you just described usually, but so I wonder again if this is somewhat delayed effect from L-Trombopac and cyclosporin. And the last point I would make about the hemoglobin, this is like how the study was designed. So technically, if your hemoglobin above 11.5, you are supposed to hold the drug, which I think is nonsense in my opinion. Those patients are still anemic. I mean, if you are below 13, you are anemic. There is a theoretical concern about thrombosis when you overshoot, but I've never it's very, very uncommon to see a patient with MDS overshoots. It's the same discussion with ESA. Most of this has come from solid tumor literature. So I cannot tell you not to follow the label, but if the patient is feeling well, with a hemoglobin of 12, I think it's reasonable to let him be and just observe what happens.
I think then we can safely say that the cyclosporin, and he's almost on reduced dose of cyclosporin. I'm tapering the cyclosporin, and L-Trombopag also I plan to stop it because his platelets are maintained and he's transfusion. I mean, he doesn't require any platelet transfusions. Hemoglobin has been taken care of. I mean, he responded beautifully with just 2 to 3 doses of luspatercept. So even I can't say whether it was effect of the cyclosporin and L-Trombopag, but it was almost like magic, like from 6 going on to 9 with just 1 dose. I don't know how.
So he was on the 3 drugs together, like the cyclosporin and the L-Trombopag.
Yes. Initially, yeah. So and then I tapered off the second.
You should probably publish this case as well, because I'm not aware of a triple use before. This could be actually an interesting approach. Instead of ATG, combine luspatercept with L-Trombopag and cyclosporin. This could be a study.
Yeah, sure. I'll do that. Thank you so much.
Sure.
Thank you. Amit?
Thank you so much, sir, for that wonderful talk. I have 2 questions. One is regarding if any elderly patient who comes to you with a hypoplastic MDS with a high blast count, is it must that do we screen every patient such for DDX41 mutation? And if found positive for DDX41, what would be your line of management?
So I think it depends. I would not treat people with DDX41 somewhat differently than patients who do not have them from a therapeutic point of view. What I can tell you is some of those patients have a very indolent course. They do not progress as quickly and they respond to treatment better. I actually have a patient who's 97-year-old who has DDX41 mutated AML almost 2 years now and have not treated her. Her counts have been she refused treatment and probably was a good decision. For the last 2 years, her counts have hovered around, hemoglobin of 9 to 10, platelet count 50 to 60, ANC 0.8, but literally they have not changed for almost 2 years. And I have other patients with DDX41 who have been on HMA or HMA-VIN for years. So I do think as an entity, these patients probably do better in terms of their overall prognosis, but I would not treat someone differently just because they have DDX41.
Thank you, sir. And another question is, any patient who is high risk MDS transplant eligible, so what would be your cutoff for the blast percentage for the transplant, upfront transplant, number 1? And if the blast percentage is high, would you choose for HMA when, or would you go for chemo-based therapy like 3+7 and then transplant?
Yeah, both are very good questions. I think for the first question, there is no clear consensus. My general approach is that the lower the disease burden, the better. So I tend to, our own institutional practice is to get the patients below 5% to get to transplant. The European ELN guidelines say less than 10% and they can take the patient directly. I think you have to take into account also whether this is a myeloablative or non-myeloablative transplant, right? In older patients, most of them are not going to be myeloablative. So that means that the patient might progress even before they had the chance to get the GVL effect. For your second question, I would use Azaven on a case-by-case basis in terms of patients with excess blast. If they are very close to AML, like let's say between 15 to 19% blast, I potentially could use it as a cytoreductive treatment. But for other patients, I'm still waiting for Verona studies to kind of fully understand the impact of HMA-VIN in patients with MDS. But as a bridge to transplant, where you are only doing it for a couple of months or 3 months, I think it's reasonable. I think the bigger question in my mind is for patients who are not going to transplant, long-term use of HMA-VIN. And that's, I think, something we are going to find out from Verona.
Thank you, sir.
Thank you. Dr. Siddesh.
Sir, I would like to continue this question further. When we say response, a blast percentage less than 5 is okay. But then should we take into account cytogenetic response also before taking up patients for transplants? For example, I have a patient who has translocation 611 and blast percentage was only 16%. Then I gave 2 cycles of azaven. Blast percentage came down to 0.1%, but fish is still showing 55% translocation 611. So shall I wait or take up this patient for transplant?
Yeah, my approach would be to take the patient to transplant, because while we generally think that MRD negative kind of status before transplant is important, not all MRD first are created equal. Like, for example, FLT3 and NPM1, those patients, if they have MRD, they generally don't do very well, but some of them are cured with transplant. While, for example, IDH1 MRD or, the DAT, the DAT mutation, ACXL1, TET2, etc. Those patients doesn't really matter if you have persistence or not. For this particular translocation, it's tough to know for sure, but I generally would be hesitant to delay a transplant that's otherwise good to go. You have the donor, because you can give the patient another cycle of chemo and they develop renal failure or some other thing, and you derail the only curative kind of approach that they have. So my approach would be to continue, but the one thing I would consider in this patient is potentially maintenance therapy. Again, maintenance in post-transplant is not like established in MDS or really in AML in any kind of high-level setting, but I have actually been using HMA-VEN as maintenance. There's an ongoing trial called Viality that looks at HMA-VEN versus can't remember, versus placebo, I believe, in post-transplant setting, which will answer this question. But I have been using it on a case-by-case basis to try to cover the first couple of years after transplant to reduce the chance of relapse, if you can. Because I agree with you, these patients are certainly high risk of relapse post-transplant, but it's not clear to me that delaying the transplant, first of all, is this a destiny? Like, is the patient destined to be high risk? Like, is delaying transplant going to really reduce the risk? I don't think we know. But my bigger concern, as I mentioned, is that something might happen that might derail the transplant altogether.
Thank you, Dr. Siddesh. Amit, you have another question?
That's all, sir.
No. Okay. If a patient has done extremely well on HMA, blood counts have normalized absolutely, and is tolerating also treatment extremely well, he is a transplant eligible person. There are no contraindication. You'll transplant him or you'll continue with the EZA or DESI?
Yeah, I think it depends on like the age of the patient and the discussion and the donor and comorbidities, etc. So I think if the patient is relatively, I would say in their late 60s, I think around 75 where I start hedging in terms of like, is it really worth it or not? But let's say someone in their late 60s who otherwise is a transplant candidate, who otherwise are in complete remission and have a good donor and the patient is accepting, I generally will do it, because as I like the study that we showed from the SEER Medicare is exactly to answer this question. What I tell the patient is that your chance of being alive without a transplant in 5 years is 4%. So if you are likely to die from other things, from coronary artery disease, from hypertension, from age, in that period, then probably makes sense to not to go to transplant. But if the patient otherwise has an expected survival of 10, 15 years, in my mind, it's worth considering transplant.
Sure. Dr. Ankit?
Yes, sir. Thank you so much for that wonderful talk, sir. My question is regarding use of venetoclax. You had mentioned that there are trials going on to reduce the continuous dose of venetoclax. So, what is your experience? Because most of our patients, they do not tolerate the full dose, continuous daily dose of venetoclax and develop cytopenia, and ultimately they have to stop the medicine. So, what is the lowest effective dose of the venetoclax in a month that you in your practice have used? And second, how to time the venetoclax, whether to give with HMA or whether give subsequently and to decrease that myelotoxicity?
Yeah, both are good questions. I think it's very clear that the vast majority of patients, I would argue all patients don't need continuous dosing of venetoclax, and not only don't need it, but as you said, most of them will get into trouble, infections, toxicities if you continue to dose it. And that actually not only in MDS, but also in AML. As you know, like where you draw the line between high risk MDS and AML is always vague, and it has been always interesting to me that it was widely accepted to use 14 days of venetoclax in high risk MDS, but once you are AML, once you have one extra plus 20%, then you are using continuous dosing, which again doesn't make a lot of sense. What I do in my practice in MDS is 14 days if I'm using venetoclax, and then I would reduce based on response. I have patients who go down as low as 7 days or 5 days, and I tend to reduce the venetoclax and then reduce the HMA. I do not stop. I have to say the design of the MDS trials with venetoclax is to reduce HMA before you reduce venetoclax, which is the opposite of what we do in AML, which can, again, get confusing. In AML, what I would do is a bone marrow around day 21, and if the patient is in remission, less than 5% plus, I would hold the drug. The vast majority of my patients who continue on venetoclax wind up on probably 2 weeks. I have patients who get 1 week of venetoclax, 5 days of AZA or decitabine, and get dosed every 8 weeks. Sometimes they have to extend the cycle to 6 or 8 weeks just to maintain patient without significant suppression. So certainly very important to monitor the blood counts and individualize your approach. But I think it's clear that continuous dosing certainly can lead to more harm than benefit.
Yes, sir. And one follow-up question, because you had mentioned regarding AML. So, in patients of high-risk MDS with high blast count, EB1, EB2, or patients with AML, if they have FLT3 positive or any other targeted mutation like IDH1 and 2, is there any role of triplets with HMA with venetoclax and IDH1, 2 inhibitor? Is there any role of that regimen?
Yeah, so there are ongoing studies like with the triplets. I personally, although these drugs are all available individually in the US, I tend not to use triplets in my own experience for IDH1 and IDH2 because I think the data about using IDH1 and IDH2 after azacitidine in salvage is actually pretty good. So the question in my mind is using them concurrently versus sequentially. Is there a benefit to use everything in the front line rather than sequentially? In FLT3, you might make a more stronger case for a triplet than in IDH. In IDH1 and 2, for sure, I think leaving the IDH1 or 2 inhibitor until after azacitidine failure I think is reasonable. In FLT3, I still struggle because the data from the phase 1 actually just got published in JCO just a couple of weeks ago, azacitidine, gilteritinib. The data is pretty good, but I tend to hesitate to change my practice based on single arm phase 2 trials. I always like randomized trials, especially given that we know that the AZA-GILT versus AZA was a negative study. So I think I even need a higher bar to make sure that AZA-VEN-GILT is better than AZA-VEN followed by GILT.
Right, sir. Thank you.
Sure.
Ankit had asked one question. You give HMA and VEN on the same day. Is it important or they can be on different days?
I tend to start them together because there is some data that suggests synergy. Now, let's say, and again, I don't know how, like the mechanism of getting venetoclax in India, but sometimes I have insurance trouble and I cannot get venetoclax for like 2 weeks. If I am pushed and the patient needs to start treatment soon, I generally will just go ahead with AZA and add VEN when I can. But generally, if I have the option, I always prefer to start both.
Fair enough. Dr. Priyanka, your question. Okay. Meanwhile, yeah, go ahead, Dr. Priyanka.
Good evening.
Good evening, sir, and thank you for giving me this opportunity. Dr. Zaidan, very nice talk. I just wanted to ask you if you treat P53 mutated patients at baseline any differently than the high-risk MDS.
Yeah, it has been a very frustrating disease. As you know, many of the new promising therapies have not worked very well. Clearly, my approach is always a clinical trial if I have one with whatever thing you can give. But I tend to treat those patients with the same paradigm, HMA or HMA-VIN, with trying to go to transplant. I think the main points I would like to highlight is I would not deny a patient going to transplant just because they have complex karyotype and TP53, because while many patients are not cured with transplant, there are some patients who are cured, and I don't think there is a way for us to know. The second thing is I would not deny a patient a transplant who's in remission just because they have still TP53 before transplant based on MRD. Again, there are patients who are cured, and the alternative is certain death. So in my mind, it makes sense to try. However, what I try to do, again, anecdotally, is to try to give post-transplant maintenance with the hope that you are extending the time for GVL effect from the transplant to take place. Regarding venetoclax, as you know, in AML, the data with venetoclax has not been great in TP53. We still have to see Verona results for high-risk MDS, but I tend to use the same approach, is that if I'm trying to go to transplant and the blast count is very high, I think it's reasonable to consider. But I think this is the subset that's probably least likely to benefit from venetoclax out of the different subsets in AML MDS.
So would you like to keep a lower threshold for intensive chemotherapy with a slightly higher blast than relatively otherwise healthier patient?
You could, but for me, it's all like as a bridge to transplant. So if you are trying to bridge someone to transplant, you probably can get the same CR rate or even better with azacitidine than intensive chemotherapy, and you are more likely to cause organ toxicity and derail transplant with intensive chemo. So unless there's a cost consideration or other factors, I probably go with HMA or HMA-VIN over intensive chemo if you have a TP53 complex karyotype.
Okay.
Thank you.
Is there any data on combining luspatercept with the ESA?
There is not, but we are actually kind of discussing with the company. We are hoping that a trial along those lines might happen, because I do think it's important. In lower risk MDS, we are in a situation where we have several now good drugs, and I think trying to move them earlier, like the Elman trial I mentioned, where you are giving it for patients who are transfusion independent. They have symptomatic anemia, but they have they are not yet needing transfusions with luspatercept. This is already ongoing. Or combinations like luspatercept with HMAs, luspatercept with with ESAs, as you suggest. Potentially, if imetelstat gets approved, those kind of combinations. So I think it's a very exciting time for lower risk MDS, where you can look at combinations and sequencing.
One or two questions from the audience. Anil Kumar Yadav wants to know, may I know which blast percentage is the cutoff? Bone marrow, morphology, or on flow?
For transplant or?
For transplant.
Yeah, so I think I mentioned in response to an earlier question, I tend to use 5% like as our institution. But of course, if you can get MRD negativity, that's even better. But for me, I would not delay transplant if I am in a CR in terms of like trying to clear a mutation.
So his question is whether this is 5% on morphology or on flow cytometry.
Oh, it's usually our gold standard is aspirate, basically. So aspirate, immunogen, and flow. Flow is for us is the kind of third tier. We actually introduced by this in the IWG 2023 criteria, because this is, I don't think this is like standardized anywhere else. So we did mention in that paper that aspirate is the kind of the gold standard. As good aspirate count in a 500 cell, in a good sample.
Right. Another question is from Dr. Amber. For high-risk MDS transplant ineligible, but having blast less than 5% in the marrow with refractory anemia, should we give azacitidine or EPO?
I think if the patient has excess blast, I tend to use HMA because, you know, I think, let's say you have an exceptional situation where someone is very old and very frail and, you know, maybe APOC, but if the patient is in a reasonable shape, because you are not only trying to kind of improve the anemia, but probably trying to improve also quality of life and survival. So I think an HMA would be the better option in my mind.
Another question is, in TP53 mutated MDS, will you prefer decitabine over azacitidine?
I don't think this data kind of held water, in my opinion. Neither the 10-day of decitabine, neither the difference between AZA or actually, if you know, the data with the oral decitabine seems to be the best, but again, it's not controlled, and I don't have a very good reason why oral decitabine would be better than AZA or IV decitabine. I think unless this gets shown in a randomized clear data, I would not make a distinction.
Okay. The last question is whether TPO mimetics help in improving platelets during aza-ven therapy in MDS.
I would certainly not add them together because we actually have data that adding TPO mimetics to AZA is harmful, not only not helpful, it's harmful, can increase complications. Now, in lower risk MDS, where the main problem is thrombocytopenia, you could use it as a single agent, or as we discussed with the hypoplastic MDS with cyclosporin, but I would not combine it with aza-ven.
That was the last question. So we come to an end. Thank you so much.
Dr. Shailesh wants to ask one question.
Go ahead, Dr. Satish. Is he there with us? Yeah, he's there.
Yes, sir.
Go ahead.
Good morning, sir. Regarding one of my patients, I have one patient who is 50-year-old, diagnosed with chronic myeloid leukemia, chronic phase in May 2018. And he was doing fantastic till last 4 months. Before 4 months, he lost the molecular response. I have switched to the dasatinib, and after starting the dasatinib, he had a pancytopenia. So I thought that is because of dasatinib. I switched to the nilotinib, but after starting the nilotinib also, he is having persistent pancytopenia. I did the bone marrow. The bone marrow is moderately hypocellular, adequate erythroid, decreased megakaryocyte, decreased myeloid. Karyotype showing is monosomy 7. And in the NGS, no mutation detected. Now, my question is, an RQ-PCR is 0.1%. And there is no PH chromosome in the karyotype. So will you label it this is MDS or just clonal evaluations without PH chromosome? And will you transplant this patient or will switch to the another TKI?
Sorry, just to make sure I understood. So you said PCR APL was 0.1%. I know it's negative by karyotype, but PCR APL is positive.
Yeah, yes, sir.
Yeah, I mean, I think, you know, we certainly have seen some of, like, you know, I've seen patients with MDS go into CMML or myelofibrosis go into so I think these diseases can certainly move. I mean, ultimately, for me, the question is always like kind of one common pathway. If a disease not responding to treatment with, you know, with the standard approach, I think transplant is certainly reasonable. So here you have a situation where you have 3 different TKIs. Right? You said you used nilotinib, dasatinib, and imatinib.
No, imatinib, nilotinib, and dasatinib.
Yep. So I think, you know, in a situation if the PCR APL was rising and this is the cause of failure, then switching to another TKI would make sense. But the case you are describing is not that, right? You are describing hypoplastic marrow, where you have still some PCR APL, but you have a new monosomy 7. So I do think that this is more along the lines of clonal evolution into a different process, and I do think that's something I would consider transplant for.
Thank you, sir.
Is Haidas there with us? Okay, if no, then I think on behalf of everybody, I thank you so much for sparing your so much of valuable time. You updated us, you interacted with all our friends here, and really everybody's benefited. The large number of audience from all across the world have heard you today. Grateful to you for sparing your time. Thank you.
Thank you so much, and I look forward to meeting you in Mumbai in the future. Thank you so much, everybody. Bye bye.